Hello, everyone. Wanted to thank Dr. Schreiber and Hillary for inviting me and organizing. And I'm sorry I wasn't able to be there in person. But today I'm going to talk about the International SCN8A Registry, give you an update on the kinds of work we're doing, and the exciting future that I think we have. So one of the things that you notice when you work with registry data, and we've collected data for a number of years now, is that many of the different individuals with SCN8A are on a variety of different drugs and different trajectories and cocktails. And what's needed and what the missing piece of the puzzle is the standard of care, some kind of treatment guidelines that will guide clinicians around the world to treat SCN8A in some consistent manner. So there's a wonderful project we're involved in, sponsored by the SCN8A International Alliance. A clinician network has been formed, and we are in the process of undergoing a process called the modified Delphi process to discover or come to some kinds of consensus in a standard of care. And so what I want to talk about is the role of the registry in developing that consensus standard of care. And where I'd like to go at the end of the talk is some of the patient subgroup work we're doing, where we're trying to build a predictive model where we take features, learn from the registry, predict outcomes, and improve the model so that we can find associations between different individual outcomes and particular features that led to those outcomes. So what I see as the role of the registry in developing this consensus is shown here. We're starting out with a large literature review, clinical data and experience from an all-star team of clinicians that we put together that will be led by Elaine Worrell, who was also part of the Dravet syndrome modified Delphi process that was published in 2017. And then the registry, the way I see it, is that analysis of data from the registry will help us with genotype-phenotype correlations and finding whether we have statistical support for different patient subgroups. Those two features together will help us to move forward with the consensus process, identify important points upon which we need to reach a consensus so that those guidelines can be established. So I'm going to talk a little bit about the genotype-phenotype correlations, looking at recurrent variants and an important channel function called Fast Inactivation, and then move on to the machine learning and statistical associations we're doing at the end. So here we have a reminder that we've got a database of over 365 variants and 512 individuals. And the variants are shown, the ones that cause epilepsy, in gold and yellow stars in the 4 domains and 6 segments. And there are 4 variants I'm going to highlight today that are highly recurrent, found in many individuals, and that's 850, 1475, 1617, and 1872. 1475 is in an important region called the inactivation gate. I'll talk a little bit more about later. And one of the things I discovered when looking at the data for these different variants and looking at the age of onset, so the mean age of onset for the different 850 through 1475, you see increases from 1.4 months up to 5.3 months. And I noticed that seizure freedom in percent also went from 0% in 850 up to 57% in 1475. And it makes a very nice correlation curve with an R squared of 0.9. And so that is sort of an intriguing finding, which will make us want to dig a little further to see if the relationship holds up at the individual level. These are average percentages and means that we're looking at, but the correlation is definitely something worth looking further into. We're also looking at, in this particular slide, the developmental skills that are acquired. The 25 developmental skills, the Denver 2 skills, are shown on the y-axis for each skill that's acquired. You tick up in the line on the y-axis, and the x-axis is the time, so the time between 0 and 60 months of age. And you can really notice a similar trend that we saw with seizure freedom, in that the 850 kids develop very few skills at a slow rate, whereas the 1475 kids seem to develop skills at about the neurotypical rate, which is that black line here shows the rate at which neurotypical kids gain those skills. And then you see intermediate achievement of skills for 1617, 1872, with 1617 perhaps doing slightly better than 1872. So that also is something we're looking into to try and see what kinds of associations exist between individual variants and the developmental skills that individuals with those variants acquire. Okay, now I want to move on from the recurrent variants to channel variants that are clustered together that we are going to analyze in groups because they sit in regions of the channel with a similar function. And this function that I want to highlight today is called fast inactivation. When the channel goes from a closed to an open state, it stays open for a very short time before it is fast inactivated. And that process of the molecular rearrangement that occurs during fast inactivation involves several different regions of the channel working together. So the inactivation gate actually occludes the pore of the channel in a hinged lid sort of mechanism to prevent sodium from getting into the pore and into the neuron. And that is mediated through a receptor in the D3S45 region. So these two regions act together and interact at a molecular level to promote this process of fast inactivation. There are other regions of the channel too that are involved, like the C terminus stabilizes the closed state with the hinged lid. But we are only going to talk today about D3S45 and the inactivation gate and the variants, individuals of variants in these two regions, and how similar or different these features of these patients might be. So one of the experiments we did was inspired by Tyler Youngquist, who did much of the initial work on this, where he's a dad and he's a scientist, and he was interested in the question of, do medications have different efficacy for patients with variants in the fast inactivation region versus other regions of the channel? And so what we did was we went to the registry data, we analyzed the questions in terms of which medications helped, hurt, or did neither, and we compared the group called fast inactivation against the other group. And later, we also tried to see if there were differences between these two subregions of the fast inactivation group. So on this slide, I'm going to show you some of this testing that we did with 10 drugs where we had enough data for the fast inactivation patients and the other patients with variants in different parts of the channel. And what you see are the 10 drugs here that we had data for: carbamazepine, lamotrigine, oxcarbazepine, phenytoin, valproate, clobazam on the GABAergic, and phenobarbital, and two additional drugs, levetiracetam and topiramate. So the sodium channel blockers shown here on the left, you can see, if you just kind of squint your eyes, you can see there's a lot more blue, where it was reported that these drugs were helping the people with SCN8A, whereas these individuals were reporting at a lower rate, and they also reported a higher rate of the drugs that sodium channel blockers hurt and did as opposed to help. So statistically, that ranks out to being sodium channel blockers overall are definitely more effective in fast inactivation regions of the channel versus other regions, with carbamazepine, oxcarbazepine, and phenytoin standing out as having the largest benefit to those with the variants in fast inactivation. Looking at the GABAergic drugs, there were also differences between fast inactivation and the others, in that fast inactivation was primarily reflected with less harmful effects of GABAergic drugs than the other group, which had higher rates of harmful effects. So for both sodium channel blockers and GABAergic, there are differences between those with invariants in the fast inactivation region and the other regions. Levetiracetam, as we all know, is not one of the best drugs for SCN8A, only with 1 in 10 doing well. And you can see there's a difference, although the difference is mainly in the fact that it's neither beneficial nor harmful for fast inactivation, and slightly more so for the other. Then we tried to do an experiment where we tried to divide the different fast inactivation regions into two groups, the D3S45 group and the inactivation group. And of course, the drugs were very similar in how they were reported to act in these different regions. There was only one drug that stood out, and that was oxcarbazepine, which did significantly less well for those in the D3S45 region compared to the inactivation gate, which suggests that carbamazepine may be a better sodium channel blocker choice for patients with variants in D3S45. So what we hope to do in the future is to do more testing of this kind of efficacy, which we think will aid in the effort to establish better treatment guidelines for SCN8A patients, taking variant position into account. Interestingly, if you put the D3 and the S inactivation gate on our little chart, the correlation maintains. In fact, it gets stronger. So again, it's something very interesting to look into with additional analyses. All right, in the last piece of the talk, I'm going to talk about our modeling, the modeling approach we're taking to see to what extent we can use features in the registry to identify patient subgroups, which may have different treatment guidelines in terms of what would be recommended for drugs. Are there differences among different patients and different subgroups? First of all, are there different subgroups? And this is work led by Joshua Hack in my lab. And this is the workflow where he's taken strictly only de novo gain of function patients. I'm not able to talk about the loss of function in the short time that I have. I will talk about those at some other point. But for gain of function, what we did was we chose 8 features, which I will show you in the next slide. We normalized the feature scores and did some principal component analysis. We looked for clustering and then did some statistical testing to see how many clusters there were. And then we built this ordinal regression model where we did some cross-validation to see how well these groups were supported. We know that initially, from initial tests, that there's statistically more than 0 groups. There's or 1 group. It's statistically clustered. So I'm going to show you that in the next slide. These are the 8 features that we selected initially: age at onset, time and seizure, seizure type, developmental quotient, developmental pattern, and comorbidities. I don't have time to go into how we define these different groups, but what Josh did was he placed them on a normalized scale from 0 to 1, and then he divided them into mild, moderate, severe by looking at thirds or top and bottom quartiles. So an objective way of dividing the range of the normalized score into those 3 different categories. And then he developed a single composite score for each individual based on their composite among the 8 different features. He also looked at combinations of features in his model. Initially, what we did was just to see what the data looked like in a sort of unsupervised way. We looked to see if there was clustering by eye. And you can see on this principal components plot, about 60% of the variance is explained in 2 dimensions. And you have 3 clusters, and the centroids of those clusters are shown here for the severe, the moderate, and the mild, which gave us some hope that there were actually going to be some clustering and allowing us to go further with statistical analysis. The k-means testing he did showed, in fact, that 3 subgroups best explains the structure of the data. Okay, so then he built a logistic regression model where he had a truth set of those individuals that were mild, moderate, severe. And using that truth set, he tried to predict the outcome of individual patients by using a leave one out cross-validation procedure. And what that does, this is a confusion matrix. It shows you how accurate his model was. And you can see here that 4 of the mild patients were predicted as moderate, whereas 8 moderate patients were predicted as mild, and 8 were predicted as severe. And out of the 82 successfully predicted severe patients, there were 15 that were predicted as mild and 3 as severe, as mild, excuse me. Again, the model accuracy overall for this model is about 75%. We hope to do better when we go back to the registry and choose new features based on a more of a statistical feature selection approach, where we'll look at all the features using a penalized regression model and machine learning to continue to refine the model and then test it with new data. So that process should be able to identify what features we're not seeing in the registry data that can help us with this process, refine and improve the model. And what you can see here is that if we use the model to look at the registry data, the structure of the data is such that there are about 9% mild gain of function, 26% moderate gain of function, and 56% severe gain of function. I don't have time to talk about the loss of function, but it's another 9% of the data. So this explains almost all of the data that we have. And so I call it the registry structure. To what extent it explains the population, we will find out as time goes on and we test more data. So I'm kind of running out of time here. So I'm just going to conclude by saying the synthesis would be taking the patient classification and the genotype phenotype work that we're doing, plus the clinical data and the clinical experience, and combining that all to come up with more accurate prognosis, better treatment predictions, and evidence-based standard of care guidelines. That's where we're headed. And I want to thank the team that's been working on this. We have a wonderful, talented team here at the University of Arizona in pediatrics, in my lab, in statistics and mathematics. Dr. Schreiber has been instrumental in helping us with the clinical aspects, as well as Tyler. And then Gabi and Jayetta with the International SCN8 Alliance, sponsoring the Clinician Network, the Shama Hammer Research Foundation, and folks at Combined Brain, all chipping in and helping us with this analysis. If you want to learn more about the SCN8A International Alliance, go here and you'll see more about the projects that are being done together with a group of different organizations, putting families in the center of the work. Thank you very much. I look forward to answering any questions in the live session.